So today I'm going to try and do a few things. One will be to review the indications for HIFU ablation of prostate cancer, understand the patient selection for HIFU, specifically for HIFU rather than for focal therapy in general, review some of the complications that you can potentially experience with HIFU ablation, and also some select HIFU outcomes. For those of you who are image conscious in the audience, you can get a HIFU facial, which actually helps with wrinkles, but I would not suggest you put the HIFU, the Sonoblade or Focal One HIFU probe anywhere near your face. Today we're talking about HIFU for prostate cancer specifically. We have two commercially available technologies. One is the Sonoblade system by Sonoblade Corporation, and the second is the Focal One device by EDAP TMS. HIFU was approved by the FDA in late 2015 for prostate tissue ablation. And the main mechanism of action is using ultrasound waves to generate heat, so a thermal ablation. And secondly is cavitation, so generation of bubbles and also collapse of those bubbles causing a mechanical effect on the cancer cells. So what are the current indications for HIFU when we start to look at guidelines? So if we look at the NCCN guidelines, it's included as a salvage option after prior failure, specifically radiation failure. And in this space, I actually think that focal therapy for salvage treatments, especially HIFU, is really a good opportunity to employ focal therapy. We now have a number of strategies to be able to adequately stage and localize disease and risk stratify patients in the salvage setting. So we have MRI, but we also have PSMA and Axiom and PET, and the rest of the prostate that doesn't have disease is already treated, so you don't need to apply a second treatment to that area. You just need to treat what is the residual or persistent or recurrent cancer. You do also want to generally avoid any high-risk features like seminal vesicle invasion. I will always biopsy the seminal vesicles separately in a patient who has a biochemical recurrence after radiation. The EAU and the AUA and NCCN in the primary setting, cancer guidelines really from different centers, they agree. They say that we really need more evidence to fully understand the efficacy of treatment. However, we do have some light at the end of the tunnel. We have a Category 1 CPT code that was approved by CMS that went live in January of 2021. That's 55880, which is ablation of malignant prostate tissue using transrectal HIFU. So the important aspects of this are that there's a path to reimbursement. A code does not guarantee reimbursement, but at least in my experience, so far we've had a significant success. But the second is that it does not distinguish between the primary and salvage setting. You would have to look at your LCDs for Medicare specifically, but depending on your region or Medicare MAC. And also the fact that it is for malignant prostate tissue. So previously, prior to this, it was really for prostate tissue ablation. Here, we see that it is now specific to prostate cancer. So what is the idea? What's the perfect patient for ablation? And now the criteria can be a little bit broader than this, but in general, if I want to pick the perfect patient, I want it to be unifocal. I really want that to be a potential benefit to the patient. So like Dr. Eastham, I try to avoid treating low-risk disease, and at the current time, I avoid treating high-risk disease outside of a clinical trial because I feel that more aggressive cancer needs a more aggressive treatment. We want it to be isolated from vital structures, so that will be the neurovascular bundle ideally, bladder, neck, membranous urethra as well. And ideally it would be MRI visible so that you know where to treat and how much to treat, and it allows you to apply a safety margin, which will account for either registration error of when you treat it, or secondly, the MRI generally underestimates tumor volume by about 30%. And then finally, absence of high-risk features, like I mentioned before. We have MRI, which is a reasonable way to locally stage patients. Evidence of seminal vesicle invasion or extracapsular extension, or gross extracapsular extension, I should say, may be better served with more aggressive treatment options. So what are the contraindications? Well, I'll say here potentially relative contraindications to HIFU. One would be gland size, depending on the system that you use. It can be anywhere from 35 to 60 cc's, but the most important aspect of it is really the AP diameter of where your lesion actually is. And what do I mean by that? What I mean by that is that your HIFU beam can only reach so far, and so if the area or whether your cancer is that you intend to treat is beyond that zone, then your HIFU beam can't reach it. And so here you can see this is the second zone here. If it's within that, you can treat it adequately. If it was higher than that, then you really wouldn't be able to get energy there adequately. Large calcifications can be an issue, really greater than 1 centimeter. If you see significant shadowing on the other side of the calcification where you can't identify prostate tissue, then that means that you're not going to be able to get energy past that calcification. You can, in some cases, these may be amenable to TUR, so you can remove those calcifications. Also, inflammatory bowel disease, so ulcerative colitis and Crohn's, due to the risk of fistula. And I have radiation ×2 here. I'm talking specifically about men who have had radiation and then a salvage radiation treatment as well. So I've had men who've had external beam and may have salvage HDR. And in those cases, the rectum there can be have significant radiation doses, and so I would consider that an absolute contraindication to HIFU in my experience. Also, brachytherapy seeds, and this I would consider a relative contraindication. The reason is that you really want to avoid seeds that are closer to the posterior capsule of the prostate and also Denonville's fascia. However, the same principles apply that you can have, with brachytherapy seeds that are in your HIFU beam, can result in unpredictable dispersion of energy, and unpredictable dispersion of energy can mean that you may not get the adequate treatment doses that you want in all cases. So what are the common things that we can see with HIFU? So retention rates about, and this is from a recent systematic review that was published, so here you see ranges across different studies, 7 to 27%. In my own experience with focal therapy in general, it's around 20 to 30%. Even if the patient voids in the recovery room and they go home, they can, depending on the volume of the prostate cancer that you treat and also the size of the prostate, these men can have difficulty in going to retention afterwards. You can have urethral sloughing, but that's been really less of a concern now with urethral sparing techniques, essentially not ablating circumferentially around the urethra. Infection is something important to counsel your patients regarding UTI and potentially epididymal orchitis. I'll go a little bit later through erectile dysfunction and incontinence, but fistula is something that we're always concerned about. This is what I think is sometimes inappropriately so associated with contemporary HIFU, which really is not the case. So because of that, I'm going to spend a little bit of time trying to understand how do we prevent this from happening. Now, both systems already have significant safety mechanisms that are already in place to help prevent this from happening. And these are lessons learned from early experience with whole gland HIFU. So when we think about what is already in place, we have balloons that are in the rectum that are circulating cooling fluid to keep the rectum cool. There are mechanisms to automatically detect where the rectal wall is and readjust the probe. And there are other technical aspects that we do to prevent that from happening as well. So we don't want to retreat the posterior zone, because you're going to have a lot of energy concentrated in an area. And here, this shows you the arc of the posterior zone with the sonoblade system. And generally, you want to plant above the prostate capsule, slightly above, maybe 1 to 2 millimeters. Your ablation will extend a little bit beyond that, so that just gives you an additional safety margin. You want to, how do you avoid near-field heat? What near-field heat means that everywhere proximal to where your focal point is that you're ablating is receiving energy, and that's going to absorb that energy and generate heat. So you can take pauses to allow for cooling. Sometimes I'll stop the machine for 5 minutes, go and maybe run to the bathroom and come back if I have time to, and then resume the treatment. And then you can observe the images and see that hyperechoic areas start to improve. You can compress the fat by adding additional water into the balloon. What that does is that fat generally can absorb a lot of energy, and that'll be seen as it becomes more and more hyperechoic. If you compress that fat, you can prevent some of that energy being absorbed there. and also near-field monitoring. So what do I mean by that? Here you can see this is what we call the reflectivity index monitoring. This is the box that tracks here's the prostate right here. This is the area that we're following closely, and this is our rectal wall. This is our balloon. So here what we want to make sure is that area is not expanding, it's not becoming very bright, and you have to pay attention to this throughout the procedure. So let's jump into some of the outcomes of HIFU. And so unfortunately I don't have time to go through many studies, but I will review some of the studies that I think are pertinent here. This was a study produced by the UK group. This is Taimur Shah, who works with Hashim Ahmed at Imperial College. They propensity score matched patients with radical prostatectomy with those men undergoing focal therapy. The vast majority of these focal therapy patients were actually HIFU. Cryo was applied to some anterior tumor. So what did they match by? These are the variables here. I'm not going to state them out specifically, but here you can see that they were pretty rigorously matched, resulting in about 250 patients per arm. So what do we see here? So the definition, the primary outcome of interest in this study was failure-free survival. That was defined as any local salvage, systemic treatment, or metastasis. And I will say for this specific analysis, focal therapy was allowed a second treatment. So a repeat treatment with focal therapy was not considered local salvage. And what do we see here? So what we see is at 3 years, that difference was 86 to 91%. 5 years was 82 to 86%. And 8 years was 79 versus 83%. Essentially, there's no difference. You can see the confidence intervals overlapping. Of those in the HIFU group, approximately two-thirds of those were Gleason grade group 2 or above. And the vast majority of these patients, like I mentioned before, underwent HIFU. So for those of you who are thinking, oh, well, that's cheating. You can't allow a second treatment of focal therapy. Let's see what the data looks like. So this is any local salvage. So that includes a repeat treatment with focal therapy, systemic therapy, metastasis, and also any adjuvant XRT that was applied. Message here is essentially the same. No significant differences at those time points. This is a study out of Europe as well, about approximately 1,000 patients from 2 centers, median follow-up of 36 months. The vast majority of these patients were clinically significant disease. Here, biopsy failure-free survival, this was defined, these are for-cause biopsies. So these are patients who have a rise in their PSA, or they have MRI imaging that demonstrates a suspicion for recurrence. And here you can see that at 2 years, it was about 86%. At 60 months, it was 64%. At 96 months, was 54%. Now, in the U.S., we are a little bit more, I would say, maybe obsessed with the histopathology immediately post-treatment. And so generally in my practice, I will biopsy these as part of a standard protocol biopsy at 6 or 12 months. Treatment-free survival. And treatment-free survival, again, allows for a second focal therapy, a second ablation. This is including a second ablation, was 85% at 2 years. At 60 months was essentially 60%, and 46% at 96 months. Now, of these salvage treatments, about 73% of these were actually a repeat ablation, so not actually yet transitioned to definitive treatment. So what does it look like if we say, what is, as Dr. Easton pointed out, a reasonable endpoint that, or clinically relevant endpoint that the FDA is now looking at is treatment-free survival from radical or whole gland therapy. And here you can see that short and intermediate term outcomes are actually quite good and comparable to some more definitive treatments up front. So this, I love this slide, and I also hate this slide, because the reason is because you really have to try and pool data from different sources. And there's, of course, my disclaimer is going to be there's significant bias in this in the focal HIFU cohort. The active monitoring, radiotherapy, and radical prostatectomy are taken directly from the PROTECT study. Focal HIFU is coming from the systematic review. The systematic review that I mentioned earlier that was recently published. So if we look at incontinence at 6 months. This is defined as using essentially any pads. This is pad-free continence, and with HIFU radiation and active surveillance, that's really quite low. And in fact, in my experience, it's actually incontinence with HIFU has been even with HIFU or any focal therapy has even been lower than that. With radical prostatectomy, it's 46%. How many prostatectomists in the room tell their patients that 50% of them are going to be wearing a pad at 6 months? I didn't think I'd get anybody. Okay, how about we look at erectile dysfunction? Here you can see that really this has already been established that focal therapy and in general, and specifically focal HIFU, have excellent preservation of functional outcomes. What we ultimately want to ensure is that we're giving them appropriate cancer treatment. And also I'd ask how many, again, this is from the PROTECT trial, so 67% of men had erections sufficient for penetration at baseline. So that just something to consider there. Urinary stricture is relatively uncommon. Again, like I mentioned, one important aspect is that in some men we can preserve ejaculatory function. This is unreasonably important to a lot of men who are seeking cancer treatment. So I'd like to end with this quote. Hugh Hampton Young, he became the chief of urology at Johns Hopkins in 1897. At the age of 27, actually, and he wrote this article in 1937, 3 years prior to his death. And he said that we have shown that in early cases, a hemiprostatectomy may be sufficiently radical. The removal of that half of the prostate in which the carcinomatous nodule lies, along with its capsule and seminal vesicles and vas deferens, may be entirely sufficient.